Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome back to another episode of the Healing Pain Podcast. Today, we're talking about analgesic medications and how they can have both a positive and a negative impact on how your muscles function. Analgesic medications are simply medicines that are used to alleviate pain. You may have seen these or seen them marketed as painkillers or pain relievers. Technically, the term analgesic refers to any medication that provides pain relief without putting you to sleep or causing you to lose consciousness. There are many different types of medications that have pain relieving properties. Some people tend to kind of lump these all together, but there are actually different groups or different types of medications. Some common names you might have heard of are non-steroidal anti-inflammatory medications such as Nsaids. These include things like Aleve and Advil. Another group are narcotic opioids, things like oxycodone and morphine. And then another common group are non-opioid analgesics. Typically, what falls into that category are things like acetaminophen or Tylenol. In many cases, the effective treatment of chronic pain may include one or more of the analgesic medications I previously mentioned. However, the use of analgesic medications can be potentially challenging for physical therapists because they're faced with a paradox. On the one hand, an analgesic medication may alleviate pain, which you may think makes it easier for people to move and function. But yet, on the other hand, these medications may negatively impact the physiology of your muscles, of your nervous system, and other parts of your body. Here to talk to us about analgesic medication is Dr. Bahar Shahidi. Bahar is a physical therapist and a researcher investigating how analgesics impact muscle physiology, pain, as well as physical function. She is an assistant professor in the Department of Orthopedic Surgery at the University of California at San Diego. Her academic background includes a bachelor's in chemistry, a doctorate degree in physical therapy, and a PhD in neurophysiology. Her current research focuses on muscle physiology changes in the presence of chronic spinal pain. On today's episode, we discuss how analgesic medications impact clinical outcomes in people with chronic low back pain, how analgesic medications impact exercise responsiveness, how to time the use of analgesic medication relative to physical therapy treatment, and how to balance medication use and exercise for optimizing patient outcomes. Okay, let's begin and let's meet Dr. Bahar Shahidi and learn about how analgesics impact muscle physiology. Hey there, Bahar. Thanks for joining me this week on the Healing Pain Podcast.
Hi there, Joe. Thanks for having me.
You published a paper in the 2021 PTJ, the Journal of Physical Therapy and Rehabilitation, and the title is Analgesic Use During Exercise-Based Physical Rehabilitation in Individuals with Low Back Pain, a call to action. I love those words, a call to action. And I said, all right, well, if someone's got a call to action, then we're going to talk about it on the podcast. So thanks so much for joining us and talking about analgesic use during basically exercise, which is what we do as physical therapists primarily. And you have some really good data on it. And there's also some like gaping holes in the literature too.
Absolutely. There are more gaping holes, I would say, than there is information, particularly in people that have any type of pathology, and that's with or without pain. So I think one of the main points that we wanted to bring up is that a lot of the data that's out there on analgesic use is done in healthy people. Interestingly enough, because analgesic use, you would think that more information exists on analgesic use in people that have pain or some kind of chronic pathology. But particularly in the context of exercise, there really is not a lot of information on how analgesic medications influence an exercise protocol and what you're trying to accomplish with exercise-based rehabilitation. So this was kind of one of those. The call to action was to try to highlight and bring to the forefront this big issue that, we as physical therapists are constantly trying to balance, what we're trying to do in terms of improving someone's physiology and recovery and muscle stabilization and activation, but we're trying to battle with pain at the same time. So what are our tools that we can use to accomplish that. And we probably need to know a little bit more about how those things interact.
Great place to start. And obviously there is a place for pharmacologic pain management in rehabilitation, because sometimes things tend to swing way, obviously opioids were hot and still are unfortunately hot in certain populations. And then things kind of swing over to like absolutely no opioids, but there's a place for pharmacologic management here.
Yeah. And I think it's important to recognize that pharmacological management, I think a lot of people think of that as kind of focusing on the opioids as a primary group. And I think that is probably fair in chronic pain populations. That's certainly a very high opioid use population. And that's oftentimes a group that we as PTs see. But I also think that it's some of the more over-the-counter, regular, run-of-the-mill analgesics, Tylenol, Nsaids, ibuprofen, Motrin, Advil, all of those things we tend to think are just kind of regular, okay analgesics to use, but there are some implications for their use in what you can expect to see in exercise-based rehabilitation. So I think that those also need to be considered and not just ignored as standard of care, because right now they kind of are standard of care.
Sure.
And most patients will take them as needed. And that's in addition to the opioids, something that we probably need to pay a little bit more attention to as well.
What do we know about analgesics as far as having a positive or having any kind of impact or outcome on low back pain?
So I think that, if you look at the clinical guidelines for pharmacological management, which I think most people would argue that even before PT, even with this, PT first movement where we're trying to get people into physical therapy as early as possible, people are still getting pharmacological management before they're getting PT in most cases.
Yeah.
And the data on the effectiveness of different analgesics in isolation before any other treatment is implemented is pretty poor in terms of efficacy. So the clinical practice guidelines for pharmacological management of low back pain are kind of all over the board across the world, actually. So there's a lot of geographic variability. In the United States, it used to be that Tylenol was the number one choice or recommendation for like first line of action for pharmacological management. And now that's swinging a little bit more towards Nsaids, particularly in other countries, Australia, Europe, et cetera. And interestingly, in the US, we're the only ones that are kind of teeter-tottering between a combination of muscle relaxants and Nsaids, which there really isn't a lot of data to support, which is confusing. So the point there being, people don't really know what to do. And that's probably why we see primary care shifting a little bit more towards opioid prescription, because there isn't a great consistency or efficacy in the first line management recommendations across the world for what we're supposed to do and what we're supposed to prescribe. So the efficacy is low, the variability is high, and there is absolutely no data on the combined efficacy of analgesic medications and rehabilitation. It just doesn't exist. It's pharmacological management in isolation, and then there's rehabilitation in isolation, and there's no crossover or data that implements both of those things or pays attention to both those things as an interaction. So that's a huge gap in the information or in the literature or in the way people are even thinking about the problem at the moment.
It's almost shocking considering those two things have been put together for, it's not new, right?
Yeah, absolutely. I mean, decades we've been working together with pharmacological management, and as part of, it's integrated into a patient's care. We oftentimes pay attention when we ask, but we don't really document it either. As a pattern, I don't think, and I don't observe that many people will document just routine analgesic use unless there's a concern of, like really high opioid use, and that is a separate risk factor for other things. So oftentimes PT will just kind of, they'll ask the question, like, did you take your medication before you came? Or, what's your pain level? As part of this whole kind of pain is a vital sign type of question, people will ask, but they never document it. And so that has really left us with a little bit of a gap in even pattern generation as part of anecdotal practice. You build these patterns as part of practice based on your observations. But if you don't document it, you're not paying attention really to what those patterns could tell you over time. So that's part of the call to action as well, is, these are things that we have in our back pocket, and we oftentimes do ask the question, but we need to be more intentional about paying attention to what those answers lead to.
In your paper, there's this great image, like 4 squares, and 1 square is on the regenerative capacity of the body or the musculoskeletal system. The other is on the motor drive. 1 is on exercise tolerance, and 1 is on force production. So you're starting to say, okay, here are the areas that we should be aware of with regard to improve function. Let's start first with regenerative capacity and protein synthesis. How is that impacted? We're going to kind of go through these one by one. How's that impacted by analgesics?
Yeah. So analgesics, the different classes of analgesics have differential impacts on muscle growth, and muscle growth, the fundamental foundation of muscle growth is protein synthesis. And so if you look at Nsaids, which are one of the most commonly used analgesics in PT or during PT, you would think, this again, no data, but the use of Nsaids has been shown to reduce protein synthesis in response to exercise. This is again in healthy individuals. So a lot of the science is done in healthy people, not people that have muscle pathology or pain or other types of issues. So we're making some assumptions here. But in healthy people, NSAIDs reduce the protein synthesis capacity and muscle hypertrophy that results from that by up to 50%. So that's a really big influence on your capacity for muscle to adapt. And assuming that that's your goal, which it's not the only goal, muscle hypertrophy is not the only goal. There's a lot of neuromuscular reeducation that's happening, and that's totally fair. But if your goal is to improve stabilization, in part due to muscle hypertrophy, and somebody is concurrently taking NSAIDs, you can assume that their protein production and their ability to mount that hypertrophic muscle response is going to be severely inhibited. It also impacts endurance through reduced mitochondrial function. So it affects the mitochondrial machinery. It reduces its capacity to function. And that's through that cyclooxygenase kind of mechanism. And finally, it reduces the muscle stem cell capacity to differentiate. So satellite cells are responsible for muscle cell differentiation. And if you don't have that, or if that's inhibited, then you're not gonna make the cells that you are trying to make in response to exercise and exercise-induced muscle damage, which is the stimulating factor for muscle growth. So these three factors, the protein synthesis, the mitochondrial machinery, and the impaired satellite cell activation and differentiation, are three areas where NSAIDs in particular are known in healthy muscle to impair muscle growth. The issue here is that nobody's done these experiments in people that have pathological muscle or pain, because the ability for someone without pain or pathology to mount a response is much different, particularly if they're not limited by the amount of pain. And that's kind of the balance point, because we're trying to battle this other influencing factor. We're trying to battle the fact that somebody might not be able to reach the levels of force production that they need to elicit a muscle hypertrophic response, or just get that physiological adaptation stimulus. Right. And if we can't get them there, then they're never going to adapt anyway. So we kind of want them to be on analgesics to help them get to that level of force that they need to be to induce physiological adaptation. But then, once they reach that, they're going to be inhibited anyway. So it's a little bit of a catch-22. And we probably need more information on what the balance point is there, or maybe there's a different combination of analgesic medications that don't have that same inhibitory influence. Tylenol is a great example. It doesn't have the same inhibitory effects as Nsaids do, or at least it doesn't do that at the same magnitude, but it also doesn't provide the same level of analgesic effect. So, and then opioids, on the other hand, they don't influence, or they don't have an effect or inhibition on those kind of peripheral muscle adaptation components, but they do affect you cortically. They're a central nervous system depressant. So they're reducing your ability to hype up your motor drive, which is already inhibited by pain, right? So people don't want to use as much force during their exercises because they're inhibited by pain. And opioids then further inhibit because of their central nervous system depression type mechanism.
Right. So opioids don't impact muscle cell physiology the same way Nsaids do.
Correct.
Although it's interesting though, long-term opioid use has been implicated in hormonal changes, both male and female hormones. So I'd imagine somewhere down that pathway, and as you mentioned, all this needs to be investigated further, but there's probably some implication there for long-term muscle physiology, but just a different pathway potentially.
Yeah, absolutely.
Yeah.
And we just don't know. We don't know what the direct influences are there.
It's interesting though, the NSAID part. I mean, as you're talking, I'm getting these like flashes of post-operative patients who are extremely atrophied after surgery, specifically a total knee replacement. Athletes who injure themselves, and oftentimes they turn to Nsaids as the first line of treatment. And that's a population that we're extremely interested in maintaining, the normal regenerative capacity so they can function and be in a sport. So you mentioned exercise tolerance. Are there medications that help with exercise tolerance that I guess are beneficial for physical rehabilitation?
I don't think that there's data that support that. Like there just isn't any information about the interaction between analgesic medications in the context of exercise-based rehabilitation. The best data that's out there is probably associated with that sports population, the elite athletic population, because they're, as part of this whole sports performance kind of push, they're trying to mitigate any of the negative influences of their, I would call it overuse in many situations, right? It's not necessarily that they have a pathology or pain. They are just, they're just highly, highly functional, and they're constantly pushing their physiology. So that's probably the best place to look at data about analgesics in that context. And the data there is, that kind of leads a little bit towards the concept of timing of medication use, not necessarily which ones you're using, but when you're using them. So I think most athletes are a little bit more narrow in what analgesic medications they're taking. Most athletes take Nsaids in that type of scenario. And I think the timing of medication relative to Nsaids is important. Again, very little information here to go off of, but the information that we do have about timing is if you take the NSAID before you start exercising, you are subject to those protein inhibition, mitochondrial inhibition, and satellite cell differentiation inhibition processes. If you take it after you exercise, those same processes don't seem to be present, but it also doesn't do its job of preventing delayed onset muscle soreness or actually providing you with the analgesic effect that you're looking at. So it's like you if you take it before, then it works better in terms of the actual analgesic effect. But if you take it after, you're not using it for what you wanted to use it for anyway, in terms of the analgesic component. So I don't think that there's a great solution there other than not using an NSAID and potentially trying to go more for something that doesn't have as large of a magnitude of that inhibitory effect like Tylenol.
Although I do think with what you just said might be a good piece of information for informed consent when people decide, okay, here's my personal choice on how I choose to use this medication. Either I'm going to take it before I exercise or after I exercise, and I'm aware of what the potential side effects might be for my athletic performance, for my physical, my body, basically.
Right.
That's never, I don't think that's ever, I've never heard any professional talk about that.
Yeah, I don't think people think like that.
Yeah.
And they may actually think like that more in the world of athletics and performance, because they are, they're trying for that like top 5% of optimization, and I think that in general, physical therapists, unless they're working with that population, if you're dealing with, low back pain and chronic pain, you're not even there. You're not even looking at the top 5% for optimization. You're looking at any type of effect or any type of leg up that will help your patient tolerate what you need to do in order to gain them the stability and improved function and activities of daily living, and even just, the confidence to participate in the levels of activity that are going to be beneficial for them to manage their condition.
And does some of that apply to how we would approach this in our treatment sessions as well as physical therapists? Or are the same principles apply there?
I think so. I mean, I would imagine the way that we could, it's going to take us a while to get there. But I would imagine the way that we would use this information in practice is, number one, you just like we normally do with any type of patient, you look at where they are in the spectrum of function and what your goals are in terms of how active and how much performance based you're looking at there. How complex is that patient? And then based on that, you're providing them the education and information, as you said, about what the impact of the medications that they're taking or their options for medications are. Of course, it's not within our scope of practice to be able to try to recommend specific medications and how much, but we probably can give them some information on timing. I think that's definitely something that we can impact. And I think that we can give them some education on at least what the different types of medication can do, so that they're more informed and they can ask in conjunction with their providers and their pharmacologist and whoever else is involved in their management. You can work together to try to bring these issues to the forefront, so that they're like, this isn't just for my pain, this is also for my function. So I'm trying to, triangulate all of these things together with the patient to make sure that they are empowered to have those discussions with the people that can help manage them.
Yeah. That brings me back many years when I first worked in a hospital and in inpatient rehabilitation. And back then, many of the patients had patient-controlled analgesia, so they can just push their own button, which would give them a small dose of some type of opioid. And actually, many of us as PTs were encouraged, like before you ambulate the patient, before you get them out of bed, encourage them to, depress that button, basically. And now, as I see some of this information here, not only was I probably a pawn in some kind of, opioid game that was happening way back when, but I also look at this and I'm like, okay, well, if I had this little diagram you have in your paper, if I had this in front of me, I might be able to help, make a better decision for myself and the patient with regard to what they particularly need. So if I notice someone's having regenerative capacity, then I could say, hey, doctor, you prescribed an Nsaids for this person. I really think this person might be better on Tylenol, let's say. And the physician, this is important information for the physician as well.
Yeah. And if you think about it, the physicians already use this information in different types of settings, right? Like post-surgically, when there's I'm going to use the world of spine because that's the world that I spend the most time in, but like post-operative spinal fusions, they're not prescribing NSAIDs because they know it affects bone healing. Right. And if you think it affects bone healing and you don't think it affects any of the other tissues, right, then that's a very myopic view, right? So these guys know, and they're familiar with that concept, but they are not used to applying it to other tissues. They're just, they're bone guys. They're putting bones back together, and they're focused on their hammer and their nail. And our focus is a different set of hammers and nails. And if we just thought about it from a broader perspective, like this is an NSAID is a broad anti-inflammatory. It's affecting multiple tissues and multiple systems. So it makes sense to think that if you're influencing regeneration capacity in one tissue, you should be influencing regeneration capacity in the other. And the expectation that they're going to send the patient post-op to you and you're going to be able to regenerate their muscle when they're not allowed to take an NSAID because because their bone needs to regenerate it, Yeah. I mean, some of those things actually end up working together just because of the post-op protocols there. But those guys know, I mean, they have those, they just think about it relative to a different tissue type.
Mm-hmm. So have people reached out to you with regard to this call to action and said, this has been really interesting, great information? I know you have probably some work that you're going to roll out in the future around this topic.
Yeah. So this call to action was kind of like the opening volley for a 5-year NIH funded project that is trying to fill some of these data gaps that we bring up in the paper. And one of those things being, we don't really have any information on what the medication behaviors are for people once they are in an exercise-based rehabilitation program. So how does that, we know what they're doing outside of that, but how does being involved in PT influence their medication taking patterns, and what are the what are the components that influence that? I mean, it's not just PT, it's all of these other factors that we know also influence exercise: fear avoidance behaviors, anxiety, depression, expectations and beliefs on what they think is going to be the most beneficial for them in the long term, whether they already have some expectation that a passive modality like a medication is going to work better for them than an active modality like exercise. These are all things that influence the interaction and the success of or what your outcomes are going to be when those two things are working in conjunction with each other. So just collecting data on that is the first step. And then once we understand what the profiles are and what the influencing factors are, we can then be a little bit more intentional about paying attention to, okay, if this person, in the absence of all of these other complicating factors, is taking their medication before or after, what is their influence on exercise performance? What is their influence on their ability for muscle to hypertrophy in response to a longer, 10-week, 12-week exercise resistance strengthening program? Those are the types of questions that we're trying to answer. Once we kind of narrow down into after we have a little bit more of an understanding of what the profiles look like for patients that are taking medications in an exercise-based rehabilitation setting.
Yeah, I'd imagine studying low back pain is probably the easiest to study. You typically have a lot of data around lower back pain, or it's easier to collect data around those groups. Although, as you're talking, I'm looking at things like regenerative capacity and protein synthesis. I can't help but think, okay, well, there are autoimmune diseases, which are inflammatory processes. So there's active inflammation there. So you think you want to lower inflammation, but at the same time, we may be, causing joint destruction to happen in those populations. And then there's nutrition that comes in that has an impact on all these cellular mechanisms, because without, even if you're not taking a medication that could be negatively impacted, you still have to have proper nutrition to help all this kind of strum along.
Yeah. And that's another component. We actually have a separate clinical trial that's looking at, in this patient population, the addition of a protein supplement through the program to see, we have analgesic medication is one thing, but we also have to make sure that it's, their progress or lack thereof in terms of what is happening with their muscle physiology is not limited by lack of appropriate nutrition. So we're also in parallel looking at that as an intervention to see if we can mitigate potentially, maybe that's a combination we can look at. You can take analgesic medications, but you also have to mitigate some of the inhibitory effects by supplementing with something like protein. If that's, it's a reasonable concept, but we of course have to collect the data and see that project a little bit farther along to understand what the implications are going to be. Yeah. But those are the types of things that we are looking at in the future to try to understand, like we can pick and choose how to pair these things together to make sure that based on the patient's goals and how far along they are in the spectrum of, function and performance, that we can get it right. And this is kind of this concept of applying precision medicine to physical therapy in some ways.
I love that, precision medicine. That's really where we should be. I mean, we do know that protein needs go up when people exercise. And essentially every patient who's coming to us as a physical therapist are probably having increased protein needs. So, as you mentioned, that could be a branched chain amino acid supplement, or it could be just encouraging someone to increase their protein intake just a little bit.
Yeah, a little bit of nutrition education can potentially go a long way. And that's part of this potential conversation as well, in terms of muscle adaptation and all of the things that are required to make that wheel go round, particularly in the context of aging too, because many of our patients are older. I mean, I'm going to again talk about this from the spine perspective, but most people that have chronic low back pain are in their over 50. And we know that at the very least over 60, there are significant reductions in protein synthesis, even in the process of healthy aging in response to exercise. So there's some information about aging in these in the use of analgesic medication, but there's not a lot. And it does seem, interestingly enough, that in the aging population, the inhibitory effects of Nsaids are not as profound. But it could be because the aging population isn't able to get to that threshold anyway. So the analgesic medications don't really have that much of an influence. So these are all things. I think there are some groups that are looking specifically at aging and the impact of analgesic medications on aging populations. But it's just, one more step to understand and one more variable to understand this. It's a very complex problem, like most of our patients.
Yeah. Well, it's all fascinating. I think it's fascinating research, and I'm looking forward to you releasing some more of it, because it's information that all of us as physical therapists and other practitioners who work with people who have chronic pain, it's really vitally important information. Bahar, how can people follow you and learn more about your research as it rolls out?
Yeah, I think the best place to follow me is on ResearchGate, because I'm always updating the most recent publications from this project on that platform. And so there's like a specific project line on ResearchGate that people can keep track of, and any updates usually go in that place. And you can find that under just my name, Bahar Shahidi, under ResearchGate.
Okay, so make sure to bookmark Bahar Shahidi in ResearchGate. We'll link to it in the show notes. Of course, you can find that on the blog at the Integrative Pain Science Institute. So you can follow Bahar's work as more information starts to roll out on how analgesic medication impacts exercise-based rehabilitation in not only individuals with low back pain, but potentially others as we see more research. I want to thank Bahar for being on the Healing Pain podcast this week. Make sure to share this with your friends and colleagues who are interested in analgesic medication and, of course, exercise for rehab. Make sure to hop on to the Integrative Pain Science Institute and join the mailing list, so each week I can send you the latest update, like today's awesome podcast with Bahar. I'm Dr. Joe Tatta. We'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.